Welcome to Chapter 2, the neurophysiology of trauma and psychotherapy. And so we will be talking about psychotherapy and trauma and how trauma and therapy can play a role together. And we will study PTSD later, but really understanding what trauma is and how that plays a role within therapy. So if you've done the reading of Wheeler, and I highly recommend you do the reading because it's an easy read and it's really good information to understand. The adaptive information processing, a meta model for all psychotherapy based on how the brain works, regulation of self-healing and the neurophysiological harmony, information connected adaptively and flowing to other memory networks, forged and revised by experience. So really reading Wheeler and understanding how we have memory and how we can understand how we view that memory and change how we react to that memory will be helpful. Relationship regulates physiology and provides the context for change and growth. And that's where being the relationship person, being that person for that person, really helps within them understanding their healing and processing and moving them forward in their healing. Here are some messenger molecules to really understand in terms of norepinephrine, serotonin, epinephrine, dopamine, GABA, glutamate, things like that. Wheeler goes over that some more, so I'll let you read Wheeler for that. But those are some of those molecules that play a role within the brain. And really explaining to the patient when the brain is operating efficiently, multiple assemblies of neurons are firing in unison and information is flowing freely from one area to another. And so what really surprised me was when I saw people that were manic, that were scattered, and their memory was short. They weren't remembering things from really one conversation and appointment to the next, because they're not firing appropriately. It's not firing. It's not a free flow. And so even depression too, we call it pseudo dementia, where those neurons are not firing. They're blank. They're not making processing decisions. They can't think straight. They literally will look at you and go, I don't know, because it's not firing. They don't know, and it's super frustrating to them. They're like, I can't even watch TV. Yeah, it's not processing, it's not firing, it's not doing what it needs to do, and we need to help them with that. Here are the structures of the brain. Just knowing where they are in the brain and how they look. It's fun to look at, good information to have. We have the cortical lobes. The brain has several billion neurons, that's a lot, and tens of billions of neuronal interconnections. It's divided into three basic parts: the cerebellum, the cerebrum, and the brainstem. And so the cerebrum is the outer and uppermost part of the brain. There are 4 lobes connected by a band of axons called the corpus callosum. So looking at that, we have Broca's area is the part of the motor cortex involved in the production of speech. And damage to this area results in difficulty speaking and is referred to as Broca's aphasia. Definitely have seen that. And then the front part of the frontal cortex, or the prefrontal cortex, is executive functioning, working memory, personality. So if there's damage to that, you're going to see changes in the person. And that's also in that frontal lobe, that prefrontal cortex, where we're seeing kids with ADHD struggling. They're not having executive functioning, working memory. They're highly liable. And so with that executive functioning is decision making, planning, organization, and impulse control. And so ADHD is huge in that prefrontal cortex. And as we go through the lecture, we'll kind of understand how the brain develops and how we can get to better understanding that prefrontal cortex. Temporal lobe, implicit for hearing, interpreting language, learning and memory, emotional responses. And then the parietal lobes. The occipital lobe for vision. It's good information to know, especially if they've had a stroke and they've come to you post-stroke and they don't know why they're behaving the way they are. Looking at that, the stages of brain development, regulation, and memory. And I think this is important to really help parents that their kids are very dysregulated. And so we develop the brainstem, the limbic system, and then the cortex. We have implicit memory and then explicit memory. We start with physiological regulation, then emotional regulation, attentional regulation, and then self-regulation. And so really understanding that, especially kids that have like oppositional defiant disorder, it's really in a regulation thing. They just can't regulate themselves. And so emotional regulation will come first. We got to get them to figure out how to emotionally regulate themselves, and then they'll be able to pay attention, and then they'll be able to self-regulate. So it's really important that parents understand that yelling at your kid because they're dysregulated is not going to help. And so helping the child emotionally regulate themselves, yes, they're frustrated, they're temper tantruming, they're throwing a fit, but yelling at them is not going to help them. That's just teaching them even worse emotional regulation because you're yelling at them. And so it's important for parents to understand this. So as we go through, learning about the different DSM diagnoses and what psychotherapeutic techniques can we put into the appointment, really helping the parents understand how the brain regulates and how it goes through that regulation process is important. And really helping them know that they start with this, they go to this, then this, and then that. And so if they're not emotionally regulated, good luck getting them to pay attention. And then rapid early brain development. The developing brain is most malleable. Early prenatal, postnatal, and childhood experiences have strongest impact on brain development. Even during pregnancy, those chronic stressors are affecting the developing brain of the baby. And so it's important when we have pregnant women to really make sure that we're keeping them stable and to be keeping their environment stable to really help them develop a very healthy baby. And young children are most vulnerable to effects of trauma and maltreatment because their brain is still developing. And you will see that with children that are in foster care, they're just very dysregulated. And so when we talk about that last slide in terms of, where they are with emotional regulation and things like that, they may step back and become dysregulated in the emotions because they just don't know what's going on. So here we are talking about the right and left hemisphere functions and remembering that corpus callosum, which consists of long fibers connecting the right and left hemisphere of the cerebral cortex. And researchers have found that early stress results in decreasing hemispheric integration and increased laterality. So they have found that trauma really affects the way the brain communicates with each other. And that's one of the reasons EMDR is helpful, is because it helps the brain connect from one side to another. And we'll learn about EMDR later and how that works and fully understand that. Though we're not going to be doing EMDR, that's just not our role. You're a therapist, you have to take hours of training to do EMDR. It's a lot to learn how to do EMDR. But knowing the reason for that, to connect one side of the brain to the other because that trauma has damaged that connection. And once we can get that connection free flowing again, it's definitely beneficial for the patient. We had this slide in chapter 1, and so looking at the polyvagal theory, really understanding how to get the patient within the resilience zone. Please, Wheeler does a really good job explaining it. I won't go over it because Wheeler does such a good job, and I really want you to be reading Wheeler. Please read it and really understand the polyvagal theory because this will make sense within trauma. So, neuroception is our unconscious scanning of our environment to detect whether there is a threat and if we are safe. Feeling safe is essential for a relationship. And so feeling safe is a necessary prerequisite before any relationship can be established and before social support can be effective in healing. So in terms of any trauma and things like that, those first several appointments you may not get anywhere because they may be scanning the environment for safety. They may not be feeling safe. They may be hypersensitized. They might not be in their resilient zone. They're not ready. So we got to try to get their system to be ready to be safe. So looking at this, our first reaction is curiosity and engagement if we feel safe. This is mediated by the parasympathetic system and the myelinated vagus nerve. The second reaction, if we detect threat or danger, is fight or flight, mediated by the sympathetic system. If that response fails, then a non-myelinated vagus nerve is dominated and is mediated by the parasympathetic with a dorsal vagus shutdown or the freeze response. This is a response to life-threatening events and still present in a reptilian brain from long ago. So you will see people just shut down in the appointment. I've seen it quite a bit. I've seen people dissociate in appointments. So I really don't get into a lot of trauma with the patient because I don't have time, especially I don't have time if they do shut down. Where therapy gets an hour, I get a half an hour. And so I leave a lot of complex trauma. I assess for trauma, and I ask them to describe it briefly. Because even with briefly, it can shut people down, and then you're there with a patient who's shut down completely. You've knocked them for a loop, and that's difficult. And sometimes I have patients that say, I don't want to talk about it. So then I just put in their PTSD, we'll assess at a later date when they're safe, because they're clearly not in the mindset to be able to talk about it. And I'm not there to prod it. I don't need to know the details. I don't need to know anything. All I need to know is there's been trauma. And then I need to monitor that. As we talked about before, in chapter 1, that resilient zone, keeping them in the resilient zone so they're not fight or flight or immobilized. And so that's important when you're doing an assessment of a new patient to try to keep them in the resilient zone. Or during a follow-up, if you see they're out of their resilient zone, maybe doing a little bit of calm, deep breathing or switching the subject to get them back into their resilient zone. As we talked about in chapter 1, we have lots of trauma. And if the processing is interrupted, we can have fight or flight or freeze. So anything that is overwhelming to the individual results in information being stored dysfunctionally. And so that's important to know when we talk about trauma processing, is that the trauma may be stored a certain way and we need to get it out and we need to file it appropriately. And so that's not our role within medication management, and we really don't have time in our medication management appointments, but really understanding that and maybe explaining that to the patient if they're really not wanting to go to therapy. So we have, like we discussed in chapter 1, the traumas. When the nervous system becomes overwhelmed, people can lose the capacity to stabilize and regulate themselves. That is super important. So really understanding that, oh my gosh, they've had some things happen to them, and now, like, I don't know, that they spilt milk and now they've dysregulated. And it's not about the spilt milk, it's about everything that came before that, put them out of their resilience zone. And so when the nervous system becomes overwhelmed, people can lose the capacity to stabilize and regulate themselves. And you will see that, people will blow up in appointments, people will storm out. They're just not regulated and understanding they're not in their resilience zone at that time. So looking at this, I think what we need to take out of it, trauma into sensory input, into the locus, and then the amygdala is important. So really understanding the amygdala plays a really big role, and it mediates the crisis response and powerful emotions such as anger, fear, and rage. And so we really want to help patients tap into that amygdala and to really calm that amygdala down, because the amygdala can hyperfire and think everything's a danger when it's really not a danger. And so they can read into somebody's facial expression, they can read into a word that was chosen and things like that, really be hypersensitized, and the amygdala can get very emotional about it. So really understanding that amygdala mediates the crisis response and powerful emotions such as anger, fear, and rage. And then the components of the stress response, and we talked about this last semester in terms of the hypothalamic, pituitary, and adrenal axis, which regulates cortisol, a potent hormone that inhibits growth, immune responses, and inflammatory responses. If they're in a hyperfired HPA, we got to get them out of that to be able to get them to regulate. And I'll have people that are in hyperfired HPA that are like, I just can't lose weight. Yeah, because you got all that going on. Good luck losing weight. Your body's hormones are just in fluctuation. And we got to get you back to your resilience zone. We got to get you back into that window where your HPA is not hyperfired and you can actually think about losing weight and exercising and eating healthy. And so just understanding that component of stress response, and Wheeler does a good job going through that. So trauma, a capsule of procedural memory. So we have the somatosensory feelings, the autonomic feelings, the emotional feelings, and in a trauma response, they can get all of those back. So if they're triggered, they can get each of those back. And so trauma is just not in one little part of the brain. It's all over. It's affecting the whole brain. And you might feel like, oh my gosh, why do they feel like that was traumatic to them? But you don't know all of the little traumas that they've had that hypersensitize the brain to file that as traumatic. And so it's important to really not judge what a patient views as traumatic to them, because you don't really know all the other traumas they may have experienced throughout their lifetime that has hypersensitized their brain to process even little things as traumatic for them. So looking at this, each capsule contains dissociated implicit memories. And so triggers for the past and significantly limit the person's experience of the present. You can see that this person has suffered significant trauma in their life. So looking at what this person has had going on, so that there is very little space in their brain for the present moment with so many disrupted neuronal networks. The greater amount of information memory dissociated, the less time one is in the present. So this person has all these things going on: attachment trauma, shame and humiliation, loss, accidents, abandonment. that's all going on in the brain. They're trying to dissociate from it. Being in the present is very difficult for them. So learning changes the pattern of the receptors. So really kind of helping those receptors reprocess is important. So memories are contained in webs of interlinking neurons. And that's really hard because it's all throughout the brain. You got to change all different neuronal patterns. And then each individual has their own unique biochemical profile. And the capacity to learn as well as to retrieve previous learning depends on the specific mode or feelings at the time of the experience. So, we don't know what else they have stored in there, and it's difficult. And the more intense the emotion, the more likely the memory will be etched into an enduring template. And so we talked about that with Toussaint and Fitzpatrick. You know how they mentioned that we have these neuronal pathways and we can dig these pathways in the brain. I kind of explain it to the patients kind of like sand and a flow of water. At first that flow was very narrow, it was very little, and as the water came through, it just kept digging a pathway, and now it's a culvert. And so that's kind of how the brain is, and kind of restructuring how those pathways are built in there. When you find yourself going down one of those pathways, like literally just tell yourself, stop. I'm going to think about something else. And then soon enough, those pathways will get less and less. But it's being present, but it's very difficult to be present when you're in that hyper aroused state. And then the effects of disrupted brain development, a cascade effect of developmental insult, dysfunctional development of lower brain functions undermines subsequent develops. So if there's an insult to the brain at 2 years old, going forward, that brain may develop differently than another person's brain. And so I think it's important when we talk about trauma and really understanding if there's childhood trauma. And when children come to your appointment very dysregulated, kind of understanding, was there trauma, especially foster children? We may see a lot of foster children and get psychological evaluations for that. So really understanding if there's been trauma, it's really affected the brain development. So here is the resilient zone that we talked about at the last appointment, kind of goes up and down. And you can have trauma, and some people can go down and stay in their resilient zone. And other people may go up and down and really struggle to get back into that resilient zone. And like we talked about last chapter, edgy, irritable mania, anxiety, panic, angry outbursts, and pain when you're hyper fired on the top. And then on the bottom, you may become dissociated, depressed, sad, isolated, exhausted, fatigue, or numbness. So when people present and you see what's happened, try to find out where they are in their resilient zone. And then we had this before. Here's some things that can happen when they're outside of their resilient zone. So there's kindling. So that's important. So neurons that fire together wire together. Kindling refers to lowering of the excitability threshold of neurons, rendering the person increasingly likely to develop certain symptoms. So kindling refers to really, the more trauma you've had, the less ability for the neurons to stay in that resilient zone. They are now hypersensitized. And each additional trigger may so not trigger someone else who hasn't had all those traumas. Now are hypersensitized and kindled, kind of like you think about kindling for a fire. So here we look at defense mechanisms. The autonomic nervous system there, people develop these defense mechanisms, and really understanding what the person's defense mechanism is and how we can, in therapy, to help them understand their defense mechanisms and to process their defense mechanisms. Like, especially in cognitive behavioral therapy, a person, I need to control everything. I need to control everything. I am a bad person. It never happened. Working through that. And then here's, in terms of defense mechanisms, addiction and rationalization. So ways for people that have taken those defense mechanisms a different level. And so here, another defense mechanism, shame, avoidance of the child part, reliving the trauma memory. So just a lot of shame. So if you see a person with a lot of shame, what are they hiding? What are they not wanting to address? And like I talked about before, therapy is going to bring up a lot of those emotions they don't want to bring up, but to heal, they have to bring them up. So attachment schemas, looking at this, and then Wheeler goes over it more. So we can have a secure attachment, avoidant, ambivalent, or disorganized. And so with adult attachment, they're secure, dismissive, preoccupied, unresolved. So here are some core negative beliefs in children and adults that can be because of attachment. I am not important. I'm unlovable. I'm not good enough. I'm damaged. I'm worthless. I am bad. I'm a failure. Kind of part of that attachment, how their loved ones made them feel, and really understanding and processing that through therapy. Here's just some healthy relationships. Positive affect states in the parent-child relationship are the basis of secure attachment. And you will see this in kids that you will treat. The parents are disengaged, they're yelling, they're upset with the patient you would be treating. And it really is an attachment thing. And really, them going to therapy will help regulate the child better. So this is the basis for and foundation of mental health and resilience for these children, is really getting a positive, healthy relationship between the parent and child. And so both optimal development and effective psychotherapy promote an expansion of the biological substrate of the human unconscious, the right brain, which is considered the dynamic core of the implicit self. So really helping with that attachment within the children, especially if they're in foster care. So attachment in the therapeutic relationships, our brains are wired for connection, but trauma rewires them for protection. So we can have, we talked about reactive attachment disorder, RAD. So that's part of our brains are wired for connection, but trauma rewires them for protection. So when going over reactive attachment disorder, this is something to keep in mind, that they're rewired for that. So that's why healthy relationships are difficult for wounded people. And we talked about this in chapter 1. The most important determinant for successful outcome for psychotherapy is that alliance that you build. And we as nurses are really good at that therapeutic alliance. So again, like chapter 1, better, longer lasting positive outcomes when psychotherapy is combined with medication. Definitely recommend that your patients seek psychotherapy, but some don't want to do it. So us learning those techniques is important. Stabilization we talked about in chapter 1 also. Increase internal, external resources if needed, that Maslow's hierarchy. We got to get them the base, food, water, shelter, to be able to get them to proceed and go further. Some stabilization techniques. Definitely important to get handouts, a repertoire of a library of handouts for these patients. You know, therapeutic relationships. I have cognitive behavioral technique handout. I have case management. What are community resources? Where's our food pantry? Aging and Disability Resource Center. Where are nursing homes? Where are group homes? Things like that. And then where's our local DBT? Mindfulness, managing physiological arousal. Medication can help, education, stress management, yoga, and exercise. So in terms of processing, we talked about this in chapter 1, so I won't go over it more, but learning how to help the patient process. Those processing strategies that we talked about in chapter 1, that relationship, journaling, we talked about EMDR, communication hypnotherapy. So the brain develops from the bottom up. It's the bottom up. Bottom is less malleable, harder to change, rooted with unconsciousness, thoughts, feelings, sensations, emotionals, and procedural memories. But when we do therapy, we are doing from the top down. And, you know, we could try to do bottom up therapy also. So CBT is more the top down. And then the mindfulness, the EMDR, is from the bottom up. And so, depending on where your patient is in their self regulation, sometimes CBT, you got to get them back in their resilient zone to be able to do CBT. And so, sometimes you have to do bottom up and do mindfulness and limbic system techniques first to get them to be able to do top down. So psychotherapy can cause enhanced growth in neurons and neuronal networks, and that's what we want. We want to change those networks and change how they're processing and change their automatic responses to really get them to more healthier response. Change those grooves. So therapy may take a while because we're changing grooves, we're rebuilding the brain. And so we talked about this before in terms of emotion is a powerful agent of change and is synonymous with disruption. There can be no reorganization without disorganization. Important that the patient is majority of the way stable before you tackle the trauma, because they will get disorganized again. And then here is that again, how it really is, they'll get more as they grow. As you can see, the stabilization gets bigger and bigger as they grow and process. They get bigger and bigger. And so it's important to really be there and support the patient through that process. And then in summary, healing occurs as formerly isolated, disrupted, or dysfunctional neuronal networks are recreated and connected with constructive memory networks. So it's important that we're there for them and we provide harmony, integration, connection, and balance. You know, really offering them those tools that they can utilize to stabilize themselves, to create that balance. Go for a walk, drink your water, get some exercise in, meditation, things like that to help them through.